Welcome to the Michigan Trauma Quality Improvement Program. In this section of orientation, we will review hospital events. A hospital event is defined as a complication that occurs during a patient's stay at your facility. The patient's stay begins upon arrival to the emergency department or at the time of direct admission to a patient care unit and ends at discharge. For hospitals with inpatient hospice services or units that do not use clear transition indicators, such as discharge to hospice orders, assignment of a new encounter or visit number, or a change in admitting service, the end of the stay is defined as the conclusion of the acute phase of care. This does not include patients placed on comfort care during the acute phase. Do not include complications that were present prior to the patient's arrival. For example, a urinary tract infection identified and diagnosed based on testing completed in the emergency department should not be reported. Contaminated cultures that do not require treatment should also not be reported as infectious events. However, if a provider identifies a contaminant but proceeds with treatment based on those results, the event should be reported. This definition applies to all patients, including those held or boarded in the emergency department due to limited inpatient bed availability. For additional guidance, each data element includes links to its corresponding YouTube orientation video within the Resources section. The complication codes correspond to the listed hospital events. Retired NTDS variable codes will still be indicated in the data dictionary for variables that the MTQIP collaborative continues to report. The complication date is defined as the date the complication was first recognized. Recognition is based on when the criteria for the specific hospital event are met. The exact term or diagnosis does not need to be explicitly documented in the patient's medical record for the event to be identified. Abdominal compartment syndrome is a condition in which there is swelling and sudden increase in pressure within the abdominal space or fascial compartment that presses on and compromises blood vessels and end organ function. Report if the abdomen must be opened or a percutaneous drain is placed to lower the intra-abdominal pressure and relieve end organ dysfunction. Abdominal fascia left open should be reported when the abdominal wall fascia remains open for any reason following the initial exploratory laparotomy. An abthera dressing is used to manage an open abdomen in the postoperative setting. If this is documented in the patient's medical record, the event should be reported. Acute kidney injury should be reported in patients who were not receiving chronic renal replacement therapy, such as dialysis, prior to injury, but who develop worsening renal function after injury that requires this treatment during their hospital stay. If renal replacement therapy is indicated but declined by the patient, family, or guardian, the condition should still be considered present if the defined renal function and urine output criteria are met. Renal function criteria include a creatinine increase by 3 times, or a decrease in GFR greater than 75%. Urine output criteria include less than 0.3 milliliters per kilogram per hour for 24 hours, or anuria for 12 hours. Do not report this event for patients receiving renal replacement therapy solely for drug clearance. Acute renal insufficiency is defined as a reduced ability of the kidneys to perform their function, evidenced by an increase in creatinine of greater than 2 milligrams per deciliter from baseline without the need for dialysis. If pre-injury renal function is not documented, assume a baseline creatinine value of 1.0 milligrams per deciliter. If the patient's renal function declines further and meets criteria for acute kidney injury, only acute kidney injury should be reported. Acute respiratory distress syndrome, or ARDS, is a condition in which fluid accumulates in the air sacs of the lungs, impairing oxygen delivery to the body. Several criteria must be met in order to report ARDS. Symptoms must occur within 1 week of a known clinical insult or new or worsening respiratory symptoms. chest imaging should demonstrate bilateral opacities that are not fully explained by pleural effusions, lobe or lung collapse, or pulmonary nodules. Respiratory failure must not be fully explained by cardiac failure or fluid overload. Common risk factors for ARDS-related edema include, but are not limited to, non-pulmonary sepsis, major trauma, pneumonia, pulmonary contusions, aspiration and inhalation or burn injuries. For reporting, the PaO2 to FiO2 ratio must be less than or equal to 300, with a PEEP or CPAP of greater than or equal to 5 centimeters of H2O. For your convenience, a PF ratio calculator is available in the Data Dictionary. Alcohol withdrawal syndrome is characterized by symptoms such as tremors, sweating, anxiety, agitation, depression, nausea, and malaise. Symptoms typically develop within 6 to 48 hours after cessation of alcohol use and, when uncomplicated, generally resolve within 2 to 5 days. In some cases, withdrawal may be complicated by seizures or progress to delirium. The 6 to 48-hour time frame is a general guideline and should not be considered absolute. It is often difficult to determine exactly when alcohol use stopped or when symptoms began. If a patient is experiencing alcohol withdrawal, even outside of this time frame, the event should still be reported. Do not report this event if symptoms are present upon arrival to your facility or if the withdrawal is related to a substance other than alcohol. C. difficile colitis should be reported if at least one of 3 criteria is met. These criteria include the presence of diarrhea with a stool test, positive for toxigenic C. difficile or its toxins, colonoscopy findings demonstrating pseudomembranous colitis, or histopathologic findings confirming pseudomembranous colitis. Cases in which the patient tests positive for C. difficile antigen only without detection of toxin should not be reported. Cardiac arrest with CPR is reported for patients whose symptoms begin after arrival to your ED or hospital and have documentation of an episode of cardiac arrest requiring compressions, defibrillation, cardioversion, or cardiac pacing to restore spontaneous circulation. Do not capture for patients whose only cardiac arrest with CPR started prior to arrival. If you capture this hospital event, please enter the ICD-10 procedure code, date and location for the corrective procedures taken such as CPR or open cardiac massage in your registry's procedure section. A catheter-associated urinary tract infection is defined as a urinary tract infection in a patient with an indwelling catheter in place for more than 2 calendar days on the date of event, with the day of catheter placement counted as day 1. To meet capture criteria, the catheter must have been in place for more than 2 consecutive days and either present for any portion of the day on the date of event or removed the day prior. The patient must also have at least one qualifying sign or symptom and a positive urine culture with no more than 2 organisms, including at least one bacterium with a count of greater than or equal to 100,000 C/Fu per milliliter. Only cases meeting CDC-NHSN Manual CAUTI Criterion SUTI-1A should be reported. A link to the manual is provided in the Data Dictionary for your reference. This definition applies to all eligible patients, including those held or boarded in the emergency department due to lack of inpatient bed availability. A central line-associated bloodstream infection is defined as a laboratory-confirmed bloodstream infection in a patient with a central line or umbilical catheter in place for more than 2 calendar days on the date of event, with the day of device placement counted as day 1. To meet capture criteria, the line must have been in place for more than 2 consecutive days and either present for any portion of the day on the date of event or removed the day prior. For patients transferred into your facility with an implanted central line or port already in place, The day of first access is considered day 1. 2 CDC criteria may be used to identify this hospital event. These are outlined above and may be reviewed as needed. Only cases meeting CDC CLABSI criteria, LCBI, 1 or 2 should be reported, and all criteria must be satisfied within a 7-day infection window period. A link to the CDC NHSN manual is provided in the data dictionary for reference, and review of Chapter 4 is recommended for additional detail. A deep incisional surgical site infection, or SSI, occurs within 30 or 90 days following an NHSN operative procedure, with date of procedure being day 1, and involves the deep soft tissues of the incision. To meet criteria, the infection must include at least one of the following: purulent drainage from the deep incision, spontaneous dehiscence, deliberate opening, or aspiration of the incision by a physician or their representative, such as a physician assistant or nurse practitioner, with an identified organism, or if no culture is obtained, the presence of fever greater than 38 degrees Celsius, or localized pain or tenderness, or an abscess or other evidence of infection identified on examination or imaging. Deep incisional surgical site infections are further classified as either deep incisional primary or deep incisional secondary, with descriptions provided for reference. We have provided an included list of nonspecific selected NHSN operative procedures and their surveillance timeframes for your reference. A link to the CDC NHSN manual is provided under Resources, and Chapter 9 is recommended for review. Deep vein thrombosis is defined as the formation or presence of a blood clot within the venous system. To meet criteria, symptom onset must occur after arrival to your facility, and the diagnosis must be confirmed by venogram, ultrasound, or CT scan. The patient must also receive treatment with anticoagulation therapy, placement of a vena cava filter, or clipping of the vena cava. Cases should still be captured if anticoagulation is not initiated due to a documented contraindication, such as a bleeding risk, if the patient expires prior to treatment, or if the patient develops a non-extremity DVT, such as portal or internal jugular, that would otherwise meet treatment criteria. Exclude thrombosis of superficial veins, as well as patients without a documented contraindication who receive only aspirin as treatment. Additional resources are available to assist in distinguishing between superficial and deep extremity veins. Delirium is an acute onset of behaviors characterized by restlessness, delusions, and incoherence of thought and speech, which can often be traced to contributing factors such as medical illness, changes in metabolic balance, medication, infection, surgery, or drug withdrawal. Delirium can also be reported if there is a positive delirium screening tool, such as the confusion assessment method or the intensive care delirium screening checklist, or if there is a documented diagnosis of delirium in the patient's medical record. Do not capture for patients whose delirium is caused by alcohol withdrawal. Enterocutaneous fistula, or GI leak, is defined as a fistula of the GI tract, including the stomach, duodenum, small bowel, or large bowel, to the skin, open wound, or body cavity resulting from injury, breakdown, or leak of GI anastomosis. This is typically documented in the patient physical exam or by radiologic study with presence of leakage of gastrointestinal contents or contrast. Extremity compartment syndrome is described as documentation of tense muscular compartments of an extremity through clinical assessment or direct measurement of intra-compartmental pressures requiring a fasciotomy. Onset of symptoms must begin after arrival to your facility. Report as a hospital event if it is originally missed, leading to late recognition, a need for late intervention, and has threatened limb viability. Exclude if a fasciotomy is performed prophylactically without evidence of elevated compartment pressures greater than 25 millimeters of mercury. To capture myocardial infarction as a hospital event, an acute myocardial infarction, including non-STEMI type 2, must be noted with documented ECG changes indicative of an acute MI. There must also be an elevation in troponin levels greater than 3 times the upper level of the reference range in the setting of suspected myocardial ischemia. Physician documentation confirming that the acute MI occurred after arrival to your facility is also required. Organ space surgical site infections are infections that occur within 30 or 90 days after an NHSN operative procedure, where day 1 is the procedure date, according to the list in the Selected Operative Procedures table. You can review this table by clicking on the link in the data dictionary under the description area. To meet capture criteria, the infection must involve any part of the body deeper than the fascial or muscle layers that are opened or manipulated during the operative procedure. The patient must also have either purulent drainage from a drain that is placed into the organ space, an identified organism, or an abscess or other evidence of infection that is detected on exam or imaging. To meet criteria, the infection must also meet at least one criterion for a specific organ/space infection site listed in the specified sites of an organ space SSI. These criteria are found in the surveillance descriptions for specific types of infections chapter. Please report an organ/space SSI for patients that had a chest tube placed and then developed an MTQIP that required management with placement of a new chest tube, VATS drainage, or thoracentesis with positive culture. There are links for the CDC NHSN manual as well as frequently asked questions in the data dictionary for your reference. Osteomyelitis must meet at least one of the following criteria for capture: identification of an organism from bone, evidence of osteomyelitis on gross anatomic or histopathologic examination, or the presence of at least 2 localized signs or symptoms, including temperature greater than 38 degrees Celsius, swelling, pain, heat, or drainage with no other recognized cause. In addition, there must be either an organism identified from blood testing or imaging evidence suggestive of infection. If imaging findings are equivocal, this must be supported by clinical correlation, specifically physician documentation of antimicrobial treatment for osteomyelitis. Links to the CDC NHSN manual are provided in the resource section for reference. Report other post-injury complications noted in physician documentation and requiring treatment that are not specified on MTQIP or NTDS hospital events lists. To report pneumonia, patients must meet one of 2 criteria. The first criterion requires meeting one of the 3 CDC pneumonia algorithms, including all components outlined under the imaging test evidence, signs and symptoms, and laboratory sections for a single algorithm. Links to these algorithms are available in the data dictionary for reference. The second criterion includes patients who meet capture criteria for ventilator-associated pneumonia. In these cases, both VAP and pneumonia should be reported. Be sure to utilize the CDC NHSN resources provided in the data dictionary, with particular attention to chapters 2 and 6, which offer important guidance on capture criteria and infection timeframes. A pressure ulcer is defined as a localized injury to the skin and/or underlying tissue, typically over a bony prominence, resulting from pressure or pressure in combination with shear. Report all MTQIP stage 2 to 4 pressure ulcers, as well as unstageable pressure ulcers, obscured full-thickness skin and tissue loss, and deep tissue injuries. Exclude stage 1 pressure ulcers, intact skin with non-blanchable redness, ulcers that were present on arrival and subsequently progressed to a higher stage during the hospital stay, and medical device-related mucosal membrane pressure ulcers. A link to the MTQIP pressure injury staging resource is provided in the resource section for reference. A pulmonary embolism is the lodging of a blood clot in the pulmonary artery with subsequent obstruction of blood supply to the lung parenchyma. The blood clots usually originate from the deep leg veins or the pelvic venous system, include segmental pulmonary embolisms as well as fat embolisms noted on pulmonary imaging. Do not report a subsegmental PE. Consider the condition present if the patient has a VQ scan that is interpreted as high probability of pulmonary embolism or a positive pulmonary arteriogram or positive CT angiogram. Sepsis is defined as life-threatening organ dysfunction resulting from a dysregulated host response to infection. Septic shock is a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a significantly increased risk of mortality. For reporting purposes, the patient must have a culture-confirmed infection. In addition, the patient must demonstrate at least 2 of the following indicators of organ dysfunction: altered mentation or a Glasgow Coma Scale score less than 15, a systolic blood pressure less than or equal to 100 millimeters of mercury, or a respiratory rate greater than or equal to 22 breaths per minute. Alternatively, a case may be captured if the patient meets criteria for septic shock. This includes persistent hypotension requiring vasopressors to maintain a mean arterial pressure of at least 65 millimeters of mercury, along with a serum lactate level greater than 2 millimoles per liter, despite adequate volume resuscitation. The inclusion timeframe for these criteria is within 48 hours prior to and up to 24 hours following the onset of infection. For additional clarification, please refer to the resource link provided within the data dictionary. A stroke or cerebrovascular accident is defined as a focal or global neurological deficit of rapid onset that was not present on admission. To meet reporting criteria, the neurological deficit must persist for 24 hours or more and include at least one of the specified symptoms, such as a change in level of consciousness, hemiplegia, or unilateral sensory loss. Please ensure that all listed symptoms in the data dictionary are reviewed when determining eligibility. Cases may also be reported when the duration of the neurological deficit is less than 24 hours if any of the following apply. Neuroimaging demonstrates a new hemorrhage or infarct consistent with stroke. Therapeutic interventions for stroke are performed, or the neurological deficit results in death. In these instances, the diagnosis must also be confirmed by neurology or neurosurgery, or supported by the specified procedures. While the neurological deficit itself must not be present on admission, predisposing risk factors, such as blunt cerebrovascular injury or dysrhythmias, may be present on admission. Do not report cases in which the neurological findings are attributable to an alternative, clearly identifiable non-stroke cause, such as progression of an existing traumatic brain injury, seizure activity, tumor, or metabolic or pharmacologic etiologies. A superficial incisional surgical site infection is defined as an infection occurring within 30 days following an NHSN operative procedure, with the procedure date considered day 1. This type of infection involves only the skin and subcutaneous tissue of the incision. If a deeper level of surgical site infection is identified, only the deepest level should be reported. To meet reporting criteria, at least one of the 4 following scenarios must be present. 1. Purulent drainage from the superficial incision. 2. Identified organisms. 3. Deliberate opening of the superficial incision without culture or non-culture-based testing. along with at least one sign or symptom such as pain or tenderness, localized swelling, erythema, or heat. Note that a negative culture or test does not meet this criterion. Or 4. A diagnosis of a superficial incisional SSI made by the surgeon, attending physician, or other qualified representative. There are two specific types of superficial incisional SSIs, primary and secondary. Both can be used for reporting. If deeper levels of surgical site infections are present, report the deepest level only. There are links for the CDC-NHSN manual included in the data dictionary for your use. These links are very informative and offer a lot of clarifying information. Patients admitted to the ICU after initial transfer to the floor, or patients with an unplanned return to the ICU after initial ICU discharge are captured for the unplanned admission to the ICU hospital event. Include patients who require ICU care post-op due to an event that occurred during surgery or in the PACU. Do not include patients with a planned post-op ICU stay documented as such in the EMR. Unplanned intubation is reported for patients requiring placement of an endotracheal tube and mechanical or assisted ventilation manifested by severe respiratory distress, hypoxia, hypercarbia, or respiratory acidosis. For patients who were intubated in the field, emergency department, or those intubated for surgery. Unplanned intubation occurs if they require reintubation greater than 24 hours after they were extubated. If a patient is intubated as part of resuscitation for an unwitnessed CPA, please capture unplanned intubation. Even though not witnessed, if the patient is not breathing, they meet the criteria of hypoxia. Patients who are intubated for reasons other than the respiratory issues listed, such as a change in mental status and airway protection, do not meet the definition criteria and should not be reported. Unplanned return to the operating room is reported for patients who require a subsequent operative procedure at the same operative site as the initial procedure. Both procedures must have been performed in the operating room at your center. Exclude patients with planned return to the operating room after damage control surgery or staged surgical interventions, as well as patients with procedures performed in an interventional radiology suite or a hybrid OR, where the intervention is limited to a percutaneous approach. Pre-planned multi-stage approach procedures are also excluded. The same operative site usually implies there was a need to reopen the previous incision. Unplanned is defined as an acute clinical deterioration requiring operative intervention. Unplanned visit to the operating room is reported on patients with an unplanned operative procedure. The purpose of this data element is to identify patients who were initially managed non-operatively, but later experience an acute clinical deterioration requiring operative intervention. This deterioration may be reflected by hemodynamic or neurologic decline, progression of injuries such as increasing intracranial hemorrhage on imaging, worsening laboratory findings such as a decreasing hemoglobin level, or other clinically significant changes that necessitate a change in the initial management strategy. Exclude patients whose operative intervention is an unplanned return to the operating room, as these events are captured in a separate data element. Also exclude pre-planned or staged procedures, procedures performed for incidental findings, and operative interventions associated with procedures initially performed prior to the patient's arrival at your center. There are inclusion and exclusion examples listed under additional information. Ventilator-associated pneumonia is a pneumonia where the patient is on mechanical ventilation for greater than 2 consecutive calendar days on the date of event, with day of ventilator placement being day 1. The ventilator must be in place on the date of event or the day before. To report this hospital event, the patient must also meet the criteria outlined in the imaging evidence, signs and symptoms, and laboratory columns within one of the 3 CDC algorithms. Links to these algorithms are provided in the data dictionary for your convenience. Be sure to utilize the CDC-NHSN resource linked in the data dictionary. Chapters 2 and 6 are especially important as they provide essential guidance for applying the capture criteria and determining the appropriate infection timeframes. Wound disruption, also referred to at times as wound dehiscence, refers to the separation of the layers of a previously closed surgical incision. This may involve partial or complete separation with disruption of the fascia. Thank you for watching.